Hello everyone, welcome to Alacrity Explains Medicine. Today we are going to be looking at pharmacokinetics. If you have not subscribed to this channel, please hit the subscribe button, like this video and drop a comment. Thank you. So let's start. Pharmacokinetics. Pharmacokinetics is one of the two major extremes of pharmacology, which were pharmacokinetics and pharmacodynamics. So in this video, we're going to be looking at pharmacokinetics, which tells us what the body does to a drug. Now, when you take in a drug, the drug does something to the body and the body does something to the drug. So pharmacokinetics looks at what the body does to the drug, while pharmacodynamics looks at what the drug does to the body. So pharmacokinetics is the quantitative study of a drug's absorption, distribution, metabolism, and excretion. It is referred to as the ADME study. ADME, that is absorption, distribution, metabolism, and excretion. It determines the time course of drug concentration in body fluids and what tissues. There are two fundamental parameters that govern all pharmacokinetic processes, that is clearance as well as volume of distribution. We are going to look at volume of distribution and clearance subsequently with other important pharmacological or pharmacokinetic parameters. Now, volume of distribution. A volume of distribution is a measure of the apparent space. Take note, the apparent space in the body available to contain the drug. The apparent space available to contain the drug. It relates the amount of the drug in the body to the concentration measured in what? Plasma. Because volume of distribution relates the amount of the drug in the body to the concentration measured in plasma. It is not a real anatomical volume. It's an apparent space. It is not a real anatomical volume. It is a volume required to account for the total amount of drug in the body if it were uniformly distributed at the same concentration as in plasma. So a high volume of distribution, that means there's a great total body water, indicates an extensive tissue binding or sequestration. Take it that this is your tissues, this is your plasma, which is in blood. Now, when you take in a drug, it is being absorbed from each site of administration into blood, into circulation. Now, when it enters circulation, that is in plasma. The drug moves from plasma into the tissues, right? It moves from plasma into the tissues. So, when a high concentration of this drug moves from the plasma into the tissues, we say that such a drug has a high volume of distribution, which means it is highly distributed into the tissues. When a little amount of this drug moves from the plasma to the tissues, we say such a drug has a low volume of what? Distribution. So volume of distribution plays an important role in so many pharmacological processes, and the formula for volume of distribution is bioavailability multiplied by the dose of the drug divided by the target plasma concentration. So when a target concentration, a plasma concentration is needed, the volume of distribution, the dose, and the bioavailability can be used to calculate these target plasma concentration. So this is the formula for volume of distribution. So now, looking at this, volume of distribution gives us an information of the amount of that drug that is distributed into the tissues. Now for clearance measures the ability of the body to eliminate a drug. The ability of the body to eliminate a drug. The volume of plasma completely cleared of a drug per unit time. The unit of plasma of clearance is either milliliters per minute or liters per hour. The total body clearance is a sum of all organ clearance. If the kidney is clearing, if the liver is clearing, if the biliary system is clearing, any other system that's clearing. So total clearance is the sum total. Total clearance is the sum total of the renal clearance, hepatic clearance, and all other clearance. So when you're calculating total clearance of the body, you're calculating the sum total of all the clearance of the organs clearing the drug. So the formula is dose divided by the dosing interval multiplied by the concentration of that drug. For example, if you have a dosing interval of 12 hours and you have a concentration of 5 milligrams per liters and a dose of 240 milligrams, your clearance is 4 liters per hour. Bioavailability. Bioavailability is a very, very important concept. It is a fraction. Some literatures will tell you it is a percentage. It's a fraction of unchanged drug reaching systemic circulation following administration by any route. For IV administration, it is what? The fraction is 1 or 100%. For oral administration, it is less than or equal to 1. Rarely find drugs that have oral route administration to have a bioavailability of 1. It's mostly less than 1, that is less than 100%. So what this means is when one takes a drug, the unchanged drug that reach systemic circulation after so many, we're going to talk about, we said pharmacokinetics talks about ADME, right? So if you look at ADME for absorption, in the course of absorption, there are certain forms of the drug that do not get absorbed. There are certain particles or concentration of the drug that do not get absorbed. This part that do not get absorbed is outside, right? So whatever gets absorbed and reaches systemic circulation passes through different channels and gets to systemic circulation. Whatever that fraction that gets to systemic circulation of the administered drug is what we refer to as what? Bioavailability. So we have half-life. Half-life is a time required to reduce the plasma concentration of a drug by 50% during elimination. It is a time required to reduce the plasma concentration of a drug by 50% during elimination. Formula is 0.693 multiplied by volume of distribution divided by clearance. So you take 0.693 multiplied by the volume of distribution divided by the clearance, you get your half-life represented as T half. It is time for drug to be reduced by what? 50%. So if you have a drug that has a volume of distribution of 50 liters and the clearance is cleared 40 liters per hour, so the half-life is going to be 8.63 hours. So it is valid only when absorption and distribution are rapid relative to what? Elimination. It is valid only when absorption and distribution are rapid relative to what? Elimination. Half-life is inversely proportional to clearance. Inversely proportional to clearance. See from the equation, half-life is directly proportional to volume of distribution, inversely proportional to clearance. First pass effect. Now, the metabolism of drugs before it reaches systemic circulation is what we regard as the first pass effect of a drug. So it occurs primarily in the liver after absorption from the GI tract through portal circulation. Significantly reduces bioavailability of oral administered drug. So when a drug is being administered, let's say this is the gut lumen, excuse me, and this is the gut wall. When a drug is being administered and it gets into the gut lumen, it has to move from the gut lumen into the gut wall. So the gut wall now, there is reduction, there is intestinal metabolism. Some of the drugs are being metabolized in the intestine and not allowed to cross into what? Systemic circulation. Remember we said the fraction that gets to systemic circulation tells us what? The bioavailability. That's what bioavailability is about. So some of these drugs also do not even cross the wall because they are being pumped out by what we call the P-glycoproteins. P-glycoproteins. These P-glycoproteins, they pump drugs out into the lumen. They prevent drugs from being enter the systemic circulation. So some of these drugs are lost in the feces. So when we talk about first pass effect, it is the Metabolism of this drug. These drugs are metabolized in the intestine, pumped out by the pig glycoprotein in the intestine. There's intestinal metabolism. From the intestines, remember from your anatomy, you know that the portal vein carries substances absorbed in the intestine to what? The liver. In the liver, we also have hepatic metabolism by different group of CYP enzymes. This CYP enzyme metabolize some of these drugs in the liver, and a fraction of this drug now gets into systemic circulation. What enters systemic circulation after all this metabolism is what we refer to as the bioavailability. Now, this process of breaking down drugs, intestinal metabolism, hepatic metabolism, which causes a reduction in the actual concentration of the drug, is what we call the first pass effect. And this is common for what? Orally administered drugs, because they have to get to the gut lumen, pass through the gut wall, pass through intestinal metabolism, pass through hepatic metabolism before getting to systemic circulation. So first pass effect, it is the metabolism of drug before it reaches what? Systemic circulation. It is primarily in the liver after absorption from the what? GI tract through the portal circulation. It significantly reduces bioavailability, because if there's an increased first pass effect, it reduces the amount of drug that gets to systemic circulation, which is our bioavailability. So it reduces the bioavailability of what? Orally administered drugs. It also occurs in the gut wall. Remember, we said the P glycoproteins are there, and we also have the CYP enzymes in the gut wall that helps in reducing the absorption of drugs. So this is called first pass metabolism. So absorption of a drug. Now we have talked about so many parameters, so many important pharmacokinetic parameters. Now we are going straight into what pharmacokinetics is about. Absorption. We said ADME, so A for absorption. Absorption is a process by which a drug moves from the site of administration into systemic circulation. There are different routes of administration. So from the site of administration into systemic circulation is what we call the absorption of a drug. There's passive diffusion, which is the most common mechanism driven by what? Concentration gradient. There's passive diffusion is driven by concentration gradient. A higher concentration gradient will cause drug to move from one compartment to another. Only non-ionized lipid-soluble forms cross biological membranes. Remember, in our gut wall, we also have biological membranes. Biological membranes are everywhere. As long as there is a cell, the cell has a biological membrane made up of phospholipids and proteins and the likes. So only non-ionized or unionized, you can call them non-ionized or unionized lipid-soluble drugs cross biological membranes. So ion trapping. In ion trapping, weak acids are better absorbed in acidic environments compared to what? Weak bases. While weak bases are better absorbed in an alkaline environment, which means the absorption of an acidic drug is better where? In the stomach compared to a basic drug. And the absorption of a basic drug is better in an alkaline environment like the small intestine than an acidic drug. So drug absorption is affected by what? Formulation. What's the formulation of the drug? Is it a tablet? Is it an emulsion? Is it a cream? Is it encapsulated? A different type of formulation. So the more time it takes for that drug to be broken down to its absorbable form affect the absorption of that drug. So formulation is important. GI motility also affect the drug. An increase in GI motility decreases the time it takes for absorption to occur. If there's an increase in the rate of peristalsis of the GI gut, the drug, when it gets to the GI, peristalsis will push the drug into the large colon to be excreted, to the large intestine to be excreted. So this now decreases. So increased GI motility decreases absorption, while decreased GI motility increases absorption. Blood flow increases absorption. The higher the rate of blood flow, the higher the absorption, because this drug, when it passes the gut wall, it has to enter into what? Portal circulation. So the blood that carries it. So the higher the blood flow, the higher the rate of absorption. The particle size. The size of the particle determines. The larger the particle, the less the absorption. The smaller the particle, the higher the absorption. Solubility. We already said that lipid soluble drugs pass through biological membrane. So the more lipid soluble a drug is, the easier it is for that drug to pass through the biological membranes compared to a water-soluble drug, as well as the concept of the acidic medium. The more acidic it is, the better it is to be absorbed in the stomach compared to the intestine. We also have transporters like the P-glycoprotein. The P-glycoprotein, I already said, they pump drugs out of the gut wall back into the lumen. So these transporters like the P-glycoprotein prevent absorption of drugs, so they reduce the absorption of drug, while there are other transporters that promote the absorption of drugs. So these are factors that affect absorption of drugs: formulation, GI motility, blood flow, particle size, solubility, transporters, and the like. Now, what are the routes? The route specific consideration. You need to consider the route of drug administration. For oral route, we already said that what it is subject to what first pass metabolism, which decreases absorption. So absorption may be what incomplete. For rectal route, 50% of the dose avoids first pass metabolism. We said in first pass on rectal route, 50% of the dose avoids first pass metabolism. For IV, there's 100% what bioavailability, because you are infusing the drug directly into systemic circulation. So it's theoretically 100% of the drug gets into systemic circulation. There's no absorption phase. While for intramuscular subcutaneous, absorption depends on the blood flow to that area, as well as what drug solubility. The solubility of that drug, how well can it pass through biological membranes, as well as how well is there blood flow to this site, will what affect the intramuscular and subcutaneous route of drug administration. Now we're finished with absorption, we're going to distribution. Distribution is a reversible transfer of drug from systemic circulation to the tissues. Remember, it is what? Reversible. Because when drug gets into tissues, it has to come back later for its metabolism and its excretion. So it's a reversible process. And there are factors that determine the distribution, the movement of drug from systemic circulation to tissues, blood flow to the tissues. A highly perfused organ receives what? Drug fastest compared to an organ that is less perfused. Capillary permeability. We have fenestrated capillaries, we have continuous capillaries. Now, how? Because the exchange of these drugs from the blood to the tissues occur at the capillaries. Now, these capillaries, how well are they permeable? It affects the distribution of a drug. We also have protein binding. Now, drug binds to proteins in the plasma. Because in the plasma we have plasma proteins. These plasma proteins, they bind drugs. Only free unbound drugs is pharmacologically active. Please don't forget this. Only the free and unbound drug is what? Pharmacologically active. Binding to albumin limits its distribution. So if a drug binds to, let's say, albumin in plasma, it limits the absorption of this drug, because only unbound drug is pharmacologically active and only unbound drug is absorbed. So any drug bind to albumin will remain in the what? The plasma, will remain in plasma, will remain in the vascular compartment and not be distributed into the tissues. So the more protein bound a drug is, the less its volume of distribution and the less its effect. We need a higher concentration. We also have lipid solubility. These affect distribution. Lipophilic drugs cross membrane easily. So the higher the lipophilic, the lipid solubility of a drug, the higher its distribution. We have drug transporters. Remember, we said P-glycoprotein. It limits CNS entry. It also limits CNS entry. It also occurs in the gut. So efflux pumps. These are efflux pumps. They pump drug out. So it decreases distribution. While special barriers like the blood-brain barrier, which possess tight junctions, and P-glycoprotein, which restrict the entry of many drugs. We also have the placenta barrier, which is lipid soluble. Non-ionized drugs cross readily. Fetal acidosis can trap weak bases. So placenta barrier also limits the type of drug that cross the placenta into the fetus from the mother. We're done with distribution. Now let's look at metabolism, also called biotransformation, because a drug can be metabolized or transformed from an active form to another active form, or from an inactive form to an active form, or from an active form to an inactive form. So this is the enzymatic conversion of drug to a more polar water-soluble more polar water-soluble metabolite for excretion. Convert the drug from a more polar drug to a more polar or water-soluble form. Now, the more polar the drug is, the less likely it is to be absorbed through the biological membranes. And in the renal tubules, we have cells, the tubular cells, which can absorb drug. So if the metabolite is non-polar, it is lipid soluble, it can easily go back into systemic circulation. So we need to convert this drug to a more polar form, a more water soluble form, so that it does not easily pass through the tubular cells and it remains in the renal tubules and is excreted in urine for its excretion. So we have phase 1 reaction, which involves oxidation, reduction, hydrolysis. There are two phases, phase 1 and phase 2. The phase 1 is by the cytochrome P450 group of enzymes, while it often introduce or expose a functional group. What happens is basically an introduction, either introduce or is exposing a functional group by oxidation, reduction, or what? Hydrolysis. It may activate prodrugs. There are some drugs that are in their inactive forms. That's why we said it is biotransformation. It transforming from one form to another. So phase 1 can activate prodrug to produce an active toxic metabolite, can convert an inactive drug to a more active form. That's where phase 2 now comes in, which is more of what? Conjugation by glucuronidation, sulfation, acetylation. You are adding. Usually it produces what? An inactive drug. You are adding to this drug by either adding a glucuronide, sulfur, or acetylation and an acetyl group. So when this is done, it produces what? An inactive drug. Most cases, it produces an inactive drug which is highly polar, so that it does not get reabsorbed. It's highly polar metabolite for renal or biliary excretion. And the site of this metabolism is primarily or majorly the liver. It can also occur in the gut wall, can occur in the lungs, can occur in the kidneys, can occur in plasma, but the major site of metabolism is what? The liver. Now the kinetics of elimination. We have first order kinetics, we have zero order kinetics. For first order kinetics, clearance is constant. So the rate of elimination is directly proportional to the drug concentration, which means the concentration of the drug determines the rate at which the drug is being eliminated. Most drugs follow first order kinetics. Take note of this. Most drugs follow first order kinetics. It has a constant fraction of a drug is eliminated per unit time. A constant fraction of a drug is eliminated per unit time. We also have zero order kinetics. Here, the rate of elimination is constant. Rate of elimination is constant. It is independent of concentration. For first order kinetics, the rate of elimination is directly proportional to drug concentration, which means it is dependent on the drug concentration. But in zero order kinetics, the rate of elimination is independent of the concentration. The concentration of the drug does not determine the rate at which the drug is being eliminated. So it occurs when elimination pathways are saturated. For example, ethanol, phenytoin at high concentrations. We have flow dependent elimination, where majority of drug is eliminated on first pass through eliminating organs, where we have the P-glycoprotein. Drug are eliminated through organs, so it's flow dependent elimination. Zero order versus first order kinetics. We say zero order is what? There's a constant amount of elimination, while for first order there is a constant fraction, and we say most drugs use the first order kinetics. There's a constant fraction of elimination. For zero order, there's a constant amount of elimination. For zero order, there is more drug than enzyme, so the enzyme will metabolize a constant amount per hour. The drug is more than the enzyme, it's more than the enzyme can metabolize, so it's metabolizing a particular amount of drug, so the amount is constant. Every hour it takes a particular amount, a constant amount. For example, drugs with zero order kinetics, we have aspirin, phenytoin, alcohol, warfarin, heparin, and theophylline. While for drugs with first order kinetics, nearly all drugs, like we said, most drugs, there is less drugs than the enzymes, so there's no saturation. The enzymes are not saturated because the drugs are less compared to the enzymes, so the enzyme will metabolize a constant fraction per hour. It metabolizes a constant fraction per hour. Now let's look at excretion. Excretion is the removal of drug and metabolite from the body. The removal of drug and metabolite from the body. It has a primary route as a kidney, renal excretion, and liver. We'll have biliary excretion. So, but the major route of excretion is the what? Is the kidneys. Renal excretion involves three processes. There are three processes that occur in renal excretion of a drug. We have glomerular filtration. Almost all drugs are filtered, but remember we say what? Only free drugs, unbound drugs. If a drug is bound to plasma protein, that drug cannot be filtered in the renal tubules. And remember we said only unbound drugs are what? Pharmacologically active. We also have tubular secretion, active transport of what? Organic bases and acids into the tubules. We have tubular what? Secretion. There is tubular secretion of drugs into the renal tubules. Some drugs are pumped into the renal tubules from circulation. Some are filtered in the glomerulus. We also have tubular reabsorption, where there is passive diffusion of lipid-soluble drugs, non-ionized drugs back into circulation. Remember, we say the unionized drug or the unionized drug are lipid soluble, which are the unionized drugs. They are lipid soluble and easily absorbed, while the ionized drugs are what? Water soluble, so they are not easily absorbed. So biotransformation tries to convert drugs from a active form to an inactive form, or from an active form to another active form, or either way. But the goal of biotransformation or metabolism, phase 1 metabolism as well as phase 2, is to make drugs water soluble so that they don't get back into circulation, because if in their lipid form they will go back into circulation. So urinary pH and drug excretion. Weak acids, they are excreted faster in alkaline urine. Weak acids are excreted faster in alkaline urine. Remember your reaction, your chemistry, acid-base reaction from water and salt. For weak bases, they are excreted faster in an acidic urine. Weak bases are excreted faster in acidic urine. Weak acid excreted faster in alkaline urine. So manipulating the urine pH can enhance elimination in case of what? Overdose. If there's an overdose, you try to manipulate the urine pH. You know, aspirin is an acidic drug. So in case of overdose of aspirin, alkalinization of urine can help in excretion, faster excretion of aspirin. We have biliary excretion and enterohepatic recirculation. Drugs or metabolite are excreted in the bile. Excreted in bile may be reabsorbed from the intestine. You know, the biliary tract, it leads to the what? The small intestine. The small intestine. This is our small intestine. This is our biliary tract, and we have our pancreatic duct here. So the drugs that are excreted through biliary route, they have access back into what? The small intestine. From the small intestine, these drugs can be reabsorbed back into circulation again, because this is out of absorption. So it can be reabsorbed back into circulation. From circulation, it gets into the liver again, and it gets metabolized in the body, and it goes into the body and can come back through the biliary tract again. This same route. So this movement, this recirculation, is what we refer to as enterohepatic circulation. Enterohepatic circulation. So drugs that are metabolized, drug or metabolite that are excreted in the bile may be reabsorbed from the intestine. So it prolongs drug action and half-life. This process of enterohepatic recirculation, it prolongs a drug's action as well as its half-life. We have drug transporters. These are membrane proteins that actively transport drugs in or out of the cell. In or out of the cell. P glycoproteins, remember we said they are efflux transporter. They reduce intestinal absorption. They limit CNS entry. They increase renal and biliary secretion. The renal and biliary secretion, they increase secretion of those drugs out. They reduce intestinal absorption, like we have said earlier. It is important in drug-drug interaction as well as what? Resistance, for example, in cancer chemotherapy. Clinical applications of pharmacokinetics, we have loading dose, maintenance dose, and steady dose. Loading dose is the initial higher dose to achieve a therapeutic concentration rapidly. is the first dose, the initial dose, and is given in high concentration to achieve a therapeutic concentration. Loading dose is the volume of distribution multiplied by the target concentration. It is used when a rapid effect is needed. For example, in treatment of arrhythmias or seizures, you give a loading dose. For maintenance dose is the dose required to replace drug eliminated since the last dosing interval. Now, after giving a loading dose, the drug gets to the body, the drug has to be metabolized. For the metabolism of this drug, when they are being metabolized, the concentration of the drug in the body reduces. So a maintenance dose is now given, which is what? To replace the drug being eliminated since the last dosing interval. So the maintenance dose rate is the clearance versus the target multiplied by the target concentration. We now have the steady state. Steady state is achieved after approximately 4 to 5 half-life. Steady state is 4 to 5 half-lives. 4 to 5 half-lives. 4 or 5 times half-life. So it is the rate of drug elimination which is equal to the rate of drug administration. The moment the rate of administration of a drug is equal to the rate at which that drug is being eliminated, you now have a steady state. That is what is referred to as a steady state. Loading dose, you can see the formula. Maintenance dose, you can also see the formula. For steady concentration, this is a drug being administered. As the drug concentration is increasing, some part of it is metabolized. Let me explain this. As the drug concentration is increasing, some part of it is being metabolized, increases again, metabolized, increases again, metabolized. So it gets to a point where the rate of drug administration is equal the rate of metabolism. Administration, metabolism. So at this state, we say we have a what? We have a steady state concentration. A steady state concentration, I would say, is about 4 to 5 what? Half-life. The multiples of 4 to 5 half-life. At this place, we achieve what? The therapeutic range. So the clinical significance of this information is that drugs with high first pass metabolism require a what? Higher oral dose, because via oral drugs are those that have first pass effect. So a drug with a higher first pass metabolism requires a higher oral dose. For example, propranolol and morphine. Protein binding, we said, is saturable. Displacement can increase free drug. So if you can displace a drug that is bound to a plasma protein, it becomes free, and we say free drugs are what? Pharmacologically active. Half-life determines the dosing interval of a drug. So drugs with a longer half-life gives less dosing frequency. If a drug has a longer duration, it has a longer half-life, you can have once daily dosing or twice daily dosing. But a drug with a lower half-life has to be given frequently. Renal impairment, dose adjustment for drugs that are being metabolized by the kidney. If the kidneys are a patient has renal impairment, then there needs to be adjustment in the dose needed for the drugs with significant renal excretion. The drug is excreted by the kidney and the kidney is being impaired, the dose has to be adjusted. Hepatic impairment, for drug metabolized by the liver, it affects drugs metabolized by the liver. So prodrugs may have reduced efficacy. Age, pregnancy, genetics, they significantly alter pharmacokinetics. Thank you for watching. Make sure to like, comment, and subscribe to this YouTube channel. Alacrity Explains Medicine. Thank you.